techniques that we use in dermatology, in clinical dermatology. نعم تفضل. هي التعليمات اللي انتم يعني اللي مديكم اياها شنو؟ انا ما عندي مشكله بالتسجيل، بس هي تعليمات العماده. انا ما عندي مشكله. اوكي عفوا. History. First of all, what do you know about history? History, we have the chief complaint. It's divided into parts. The main part is to know what is the chief complaint, as any ordinary history you take in medicine, okay, in other branches. The chief complaint, it is the main reason that brings the patient to seek the medical advice or to seek the doctor. What is that chief complaint? What is the main problem, main reason? Okay, and what's the duration? This is the important part in the chief complaint. The chief complaint and its duration. It's very important to know duration, to know if the problem is acute or chronic or subacute. Okay, in history we always ask about onset of the problem. It is the first episode, is it the recurrent, details of development of the lesion, how it started, how it developed, how it regressed, okay, how it spread, is there itching, is there pain, exacerbation, relieving factors. If it's a chronic problem, is there seasonal variation, chronicity, and okay, does the lesion aggravate by sunlight, get worse at summer? Okay, yes. ماذا يطلع لكم؟ لا ليش ما تحجون؟ مو أنا عندي 2 groups هسه. لا
دكتورة أنا طالع يمي جوز تسجيلين.
من اللي طالع يمها؟ شو اسمها اللي طالع يمها؟ مريم. ثواني بس مريم. اوكي مو بس مريم اللي تباوع. اوكي مو ثواني شوف اذا كان بروبلم من يمي. لا احنا العرض موجود يمنا مريم، بس يمكن لانه عندش مشكله بالانترنت. ورود ده تشوفين طالع يم الشاشه؟ اعتقد مريم عندش المشكله، تحاولي تطلعين ترجعين من جديد. اوكي الصوت واضح للجميع؟
واضح دكتورة.
الصوت واضح؟
واضح دكتورة.
اوكي
عفوا دكتورة، أنا حتى ما أعرف بس صوت.
شو اسمك؟
أنا حسن.
حسن؟
نعم.
دكتورة خلي يسوون
طلعت
فين اتداخل يعني في حساب بصوت وحساب بشاشة، يسوون فين للبشاشة؟
لا اثنينهم فاتحة الحساب الصوت والشاشة. جماعة الألف استبرق تبارك. منو حضرتك؟ اسمك؟ يوسف بشار؟ زين اوكي. عندنا حتى نغطي البروبلم مالكم انتم اكثر من 100 طالب، فانا هسه فاتحه حسابين. زين مجموعتين سويتكم دخلكم نفس الوقت على مود. أنا هسه ما راح أقدر أسجلها لأنه أني باعوا. هسه أنا جماعة حيدر كاظم، حيدر عبد الرضا، الصوت واضح يمكم ويا الصورة؟
نعم دكتور كلش واضح يمي بالنسبة لي.
كلش واضح؟ تمام.
نعم دكتور.
اي كلش واضح دكتورة.
دكتورة عبد واضح.
الجروب الثاني جروب ورود لبنى، ورود فاضل، الصوت واضح مع الصورة؟ اكو صورة. اوكي، اذا ما زال موجود بالجروبين. اكو مشكلة بالانترنت لدى بعض الطلاب عندكم. نرجع نكمل.
نعم دكتورة.
اوكي، هسه انتوا باختصار عندكم فكرة عن الموضوع. احنا بس نحاول نسوي هايلايت للموضوع فيما يخص الدرماتولوجي. إن history of present illness. History يعني history divide first of all about our chief complaint. With chief complaint we ask what is the main problem that bring that patient to the doctor and what's the duration of this problem. Okay, we ask also about the history of present illness. We take many details analysis for that problem. We do the analysis for that problem. We ask about the site, the onset, is it the first lesion, is it second lesion, repeated problem, details of development, how it started, how it spread, is associated with itching, pain, is there any factors relieving or exacerbating that problem, is there seasonal variation, worsening by sunlight or not, is there any environmental contact with any environment like plants, animals, chemicals, metals that's associated with the development of that factor. Number two, we ask about the general health of the patient, not only the dermatological thing. We ask about systemic problems, if there is systemic findings like fever, vomiting, abdominal pain, diarrhea, because there are some dermatological disorders associated with systemic manifestation. Don't forget that their dermatological disease or findings associated with systemic manifestation. We ask about the main problem like fever, diarrhea, and if the patient tell you that he have this problem. Past history of dermatological disorder if this present, if the patient has a history of atopy, history of dermatitis, history of psoriasis, whatever. Is there family history of dermatological disorder? Also, there is family history we ask. Past medical history, if they're associated with asthma, allergic rhinitis, as in case of atopy, you know that atopy is related to this problem, asthma or allergic rhinitis. We said atopic dermatitis. We call this triad atopy. Is there social or about the social and occupational history? Also, we ask about hobbies, traveling history, if recently traveled to somewhere, alcohol or smoking habits. Drug history, also the patient taking contraceptive pills, if she taking any appetizers, steroids, whatever the drug the patient take, because there is some relation or some disease induced by drugs or aggravated by drugs, as in melasma, as in acne foam rash, the problem can be induced by drugs. Okay. Family history of the medical condition in the patient, and regarding females, we can ask about gynecological history, about pregnancy or menstrual history. Details of history and examination will take in clinical practice, of course. Regarding examination, the examination of a patient, we need to prepare to prepare the room in a good condition, which is good lighting. We have a bright, good light we need. And we need a good exposure for the patient. Take the permission of the patient and exposure that body part and the extension of the lesion where it go. So we need exposure, and the exposure, the proper exposure means the exposure of the body. and good lightening. What we look in examination, we look about the morphology of the lesion and the distribution of the lesion. Okay, distribution and morphology. Morphology means the shape, the configuration. Okay, distribution we see is the patient, is it localized, is that problem localized or generalized all over the body? Is it symmetrical or asymmetrical? Okay, and the shape of it, the shape of the lesion. Now we'll talk about the details about shape and configurations. Okay, at examination, on examination, please remember that we have to ask about three important things, or to examine three important things. In addition to the finding, or in addition to the main problem, we have to check three important things. First, mucous membrane in mouth, the genitalia, if accessible, and if the patient, you can examine him, and the hair and nail. Because we may find a finding that could be related, a nail finding, associated with psoriasis, for example, or associated with alopecia areata. Mucous membrane finding, we can find that in lichen planus. The problem is in the skin, but we can find findings in the mucous membrane. And so we note for any positive or negative findings. We also keep in mind if there is skin malignancies. Okay. Now, when we want to examine the lesion itself, we want to examine it, we look for two things. Or we divide this finding into primary lesions and secondary lesions. So we examine that skin finding, we determine, is it primary or is it secondary? Who can tell me what's primary skin lesion? Do you know? Anybody can help?
دكتور برايمري يعني قصده يعني هي dermatological in origin بس إذا secondary يعني due to internal disorder مثلا.
No. أنا primary شلون؟ بس قصدي واحد. نعم.
دكتور البرايمري هو الماكيول والباتس والبلاك والفيزيكل والبولي، وإذا صار عليهم manipulation by scratching أو secondary infection أو spontaneously فتكون secondary lesion.
شنو اسمك؟
ياسر عباس.
ياسر، أوكي. والطالبة هسه اللي تكلمت شو اسمها؟ قبل ياسر منو تكلم؟
دكتور أنا عبد الله.
عبد الله. اي وفد فيميل همين تكلمت، كلامهم حلو كان. هاي مشكلة لأنه اوكي كلامكم صحيح فيما يخص، بس اكو واحد من الطلاب علق انه البرايمري هو الدرماتولوجيكال والسكندري نوت. لا، هذا مو صحيح. البرايمري ليجن هو الفيرست ليجن appear. The first lesions, not the first, sorry, the lesion appear without manipulation, as Yasser said, that as a papule, as a vesicle, as a bully. Okay, that is the lesion appear as in the beginning finding. ممكن يكون papule, macule, bully, vesicle, patch, plaque, wheal, etc. البرايمري ليجن هسه راح نسوي في ليست نشوفها. Right. The secondary lesion, what is it? Is it the changes that occur on the primary lesion? Okay, or other changes that occur, like excoriations. There was a primary lesion that have itching. The patient have rub it or itching it. There is excoriations. Or crust, rupture of vesicle, there is exudate appearance and crust formation. Crust, these are secondary lesion. Okay, so we have primary lesion and secondary lesion. The primary lesions which develop as a direct result of the disease process. Okay, it is not the initial lesion is not related, not altered by trauma or manipulation, by scratching or itching. Okay, while the secondary lesion are those which involve from primary lesion. Changes that occur on the primary lesion leading to secondary lesion development. Okay, as a consequence of patient's activities, itching, for example. Clear for all? Example of primary skin lesion is a macule and a patch. What is a macule? It's a change in skin color and texture, less than 0.5 centimeters. Okay? If it's more than 0.5, we call it patch. If it's smaller than 0.5, it is macule. These lesions are flat, well demarcated, circumscribed. There is no elevation. There could be change in color or texture. It can be red, white, etc. Blue. Change in color and texture as a flat circumscribed area, less than 0.5, we call it macule. More than 0.5, we call it patch. We have papule and plaque. What are these? The papule is an elevated, firm, circumscribed lesion less than 0.5. There is an elevation, okay? Not flat as macule, there's an elevation, a papule, as in wart, like in planus, okay? If it's more than 0.5 centimeters, we call it plaque, as in psoriasis, okay? We have wheal. What is wheal? We see wheal in which disease?
insect bite.
Insect bite, urticaria. Urticaria. Okay. It is endomatous, plateau-like elevation of various size and shape. Could be small, could be large, with different configurations, different shapes, usually oval, archway, pink to red, okay, surrounded by a flare or a macular erythema. Okay, we call it urticaria. Wheals are specific for urticarias. We can find insect bite, okay, caused by transit vascular reaction in the upper derms, mainly due to vasodilatation and increased permeability of the capillaries. Characteristic lesion for urticaria. Okay. If I have an elevated area that contains fluid, we call it vesicle. Elevated, circumscribed, superficial, okay, filled with fluid. If it's less than 0.5, we call it vesicle. Example in chickenpox, herpes zoster, herpes simplex, okay? If it was more than 0.5 centimeters, we call it bully, okay? Then more than 1 centimeter, we call it bully, as in blister disease, pemphigus vulgaris, pemphigoid. Pustules and abscess. If there is elevated area, superficial, filled with exudates, it means the exudate that contain neutrophils is pus. We call it pustules. Papule filled with pus, we call it pustules, as in acne or folliculitis. If that collection of pus has accumulated in a cavity, okay, we call any large area, okay, we call it more than 1 centimeter, we call it abscess. We have here infection. There is an infection process. Nodules. A nodule is elevated, firm lesion, have depth. You remember we said papule? Papule have no depth, and nodules have depth. Okay, 1 to 2 centimeters in diameter, okay, and extend deeper in the derms than the papule. Example, erythema nodosum. النوديول يا جماعة وعندها width, elevation and width and depth. We call it nodule. Have three dimensions. These are examples of primary skin lesions. Well, what are the secondary skin lesions? Secondary skin lesion, we call it, as we said, the natural progression of a primary skin over time. Example, scales. First, I had a patch, then that patch developed scales. Is a thickened, what is the scale? A scale is a thickened stratum corneum, resulting from abnormal proliferation or discrimination of the stratum corneum of the keratinocytes. We call it scales. Excoriations, when we see excoriation, that means there is itching. That problem or that finding we found have itching, causing itching for the patient. And as a result, there is linear excoriation, okay, or scratching marks as in atopic dermatitis or in scabies. Erosions, there is erosion, which means partial loss, or erosion is a partial focal loss in the epidermis, usually heals without scarring. Okay, partial loss in the epidermis, we call it erosion. If that lesion was more deep, extending the derms and causing more deeper lesions or loss of the epidermis and derms, we call it ulcer. The erosion is a superficial, ulcer is more deep, extending to the derms. Usually ulcer heal with scarring, while the erosion heals without scarring. And we have fissure. Fissure is a longitudinal loss or break in the skin to extend the epidermis and dermis. Okay, crust. The third primary lesion is crust. Crust means oozing. There is oozing exudate, dry oozing exudate. Okay, we call it crust. اللي هي collection of serum or blood on the skin, as in most commonly we find it in herpes simplex and impetigo. Okay. Ulcer, we said there is focal loss in the epidermis and dermis, and fissure is a vertical defect in the epidermis and dermis with sharp wall, called fissure. Scar, we have area of fibrous tissue formation, fibrosis, that repeat the normal skin. A scar results from process of wound healing, wound repair, or tissue remodeling. Could be keloid scar or hypertrophic scar. The opposite of thing, we have atrophy or atrophic scar, thinning or depression of the skin due to reduction in the underlying tissue. Could be atrophy just to the epidermis or atrophy to the dermis and subcutaneous tissue. Lignifications results from chronic rubbing of the skin. Chronic time with chronic rubbing of the skin result in three things. There is thickening of the skin, hyperpigmentation, okay, and accentuation of the skin marking. This we call lignifications. Increased color, thickness, and prominent skin marking, as most seen in lichen planus chronicus or neurodermatitis and in atopic dermatitis. Also, there is special skin lesions like comedones. We have comedones is a result usually from plugging of the opening of the hair follicle by keratin material or sebum. We call it comedone. We have two types, either open comedones or closed comedones. Closed comedones, we call it whitehead or white comedones. Okay, it's a closed comedones. When that closed comedone rupture, will become oxidized. it will transfer into black color. We call it black comedone or open comedones. So we have open comedones, black and closed comedones, and open we call it black head, and closed there is white head. The black head occurs due to oxidization of the materials after it rupture and open on the skin. Okay, we see the comedones in acne. Burrows, special, we see it in scabies. Burrows is the tunnel that the mite make as it move on the skin, the epidermis. Example in scabies. Telangiectasia, small dilated superficial blood vessels that appear with pressure. We see it in rosacea, scleroderma, crest syndrome. Dilatation of blood vessels. We have terms as petechia and purpura. Petechia is a small purplish spot, less than 0.5 centimeters. Okay, we find it due to hemorrhage on the body surface less than 0.5 centimeters, while purpura is a small purplish spots on body surface, usually more than 0.5 centimeters. Okay. About arrangement and distribution, these lesions that we talked about, papules or patches or plaques or whatever, this primary or secondary lesion, we have to notice its arrangement, its configuration and distribution. The arrangement is it linear, annular? There is a picture I will show you. Is it linear distribution, discrete, all over the body, annular, circular? Is it grouped together? Okay, and the distribution, is it generalized all over the body or localized into one part, as in on just the hand or hand and feet, or any part of the body localized to that part, head and neck, example. So we have descriptive terms about lesions. Discoid lesion, if it's round or cone shape, we call it discoid lesion, as in discoid dermatitis. Targetoid lesion, if there is a lesion round areas with concentric border and dark center, we call it target lesion. Iris lesion, as an eye. We have a round lesion with a darker center and concentric border. Annular shape, ring shape, we call it annular. Examples: dome shape. We have a dome shape. We have a pedunculated, have a neck, pediculated. Verrucous surface, as in wart, has a verrucous surface. Amplicated lesion, we see that at the top of the lesion there is a tipping, okay, depression, we call it amplicated lesion. Flat-topped lesion, okay, this is regarding the shape of the papule. Arrangement, we have a discoid lesion, a coin shape, annular, a ring shape, targetoid, an iris-like lesion, linear lesion, serpentious lesion, and grouped lesion. Other features we can find: the age of the lesion, is it sharpness of the lesion, well-defined or ill-defined lesions? Is the lesion irregular, as with other geometric shapes, oval, irregular, nummular, annular, archway, gyrate? Surface of the lesion, is it rough, smooth, hard, and is it warm or hot? Putting all together, we have to notice the size of the lesion, distribution, arrangement, color. Color of the lesion, is it red, salmon pink, bluish tint, purple, as in lichen planus, pink, salmon pink is psoriasis, okay, etc. Is there secondary changes or primary lesions? The clinical signs in dermatology, example of clinical signs, you have to know, yani have an idea about Kopner and pseudo-Kopner phenomena. Kopner phenomena means what? Means that there is induction of the skin lesion or at site of trauma. On a normal skin, there's induction of a skin lesion on normal skin caused by trauma, example, scratching, surgical incision. We call it Kopner phenomena positive. Example, psoriasis. We can see psoriasis at the site of an operation or cesarean section operation. If the patient already have psoriasis, at the site of incision, can the patient develop psoriasis? This is because of Kopner phenomena positive. It is induction of skin lesion at a normal site, induced by trauma. Or example, scratching. If the patient severely scratches the skin, can develop that lesion in the area that he scratched. Okay. Or trauma. Example, vitiligo. A patient on normal skin, he hit his leg, for example, and he already have vitiligo. The site of trauma can develop vitiligo. Or burn. Example, burn. The site of burn can develop vitiligo. Okay, clear? Osbit sign. Osbit sign is when we remove this Osbit sign, we see it in psoriasis, especially in psoriasis. When we remove the thick scales of psoriasis, try to remove the thick white silvery scale of psoriasis, there is pinpoint bleeding will appear. Tiny bleeding points will appear. Okay, this we find it in psoriasis. Why this occur? Because in the pathological process of psoriasis, there will be dilatation of the blood vessels, which we can reach the undersurface of the epidermis. When we remove this skin, the thick skin, okay, the scales, this will occur a pinpoint bleeding. Barrier sign is especially we see it in systemic mastocytosis and in urticaria pigmentosa. What is that? At site of scratching, there will be swelling. Okay, edematous swelling. Okay, this because there will be release of mast cells and inflammatory mediators which contain histamine and will cause this urticarial-like lesions. Called barrier signs. See it in systemic mastocytosis and urticaria pigmentosa. Rubbing of the skin causing these lesions to appear. Nikolsky signs, this we see it in bullous disease. Okay, when we make a force or by the finger or any round subject, we rub or rotate the skin or force a little bit, rotate the skin, there will be shearing of the skin. The skin will shear off. Okay, why this occur? Because the epidermis is not adherent to the underlying skin and to the dermis. Okay, the connection between the epidermis and the dermis, there is a problem in it, as in bullous disorders. Okay, because of this effect, any shearing effect or forcing effect on the skin, rubbing or rotating the skin, there will be shearing effect. Okay. Finally, special tools and techniques that we use in the skin. Example, we can use magnifying lens in our diagnostic equipment in our examination. We see, as example, the Wickham striae and lichen planus. Discopy. Discopy means we do slight compression, as in the picture, slight compression on the skin, on the lesion, onto the skin. We'll see that there's changes in the color of the lesion. Wood lump examination and photography. We're using dermoscopy. These are some special equipment that we can use for the diagnosis, help us in the diagnosis of the skin problem. Wood lump examination, now I will explain it. Photography, taking photos. Dermoscopy, we use, this is increase the diagnostic accuracy between 30% in inflammatory pigmentary diseases, inflammatory or pigmentary disorders, hair problem. Okay, we call it dermoscopy. It's a special lens, have a magnifying effect. The special test, we can use it in our side lab room. Example, KOH examination, mycological examination. Example, potassium hydroxide smear or culture. Wood lump examination, extraction, skin biopsy, immunopathology, electron microscopy, and patch testing. These are tests that can aid in the diagnosis, to reach the diagnosis properly. Wood lump examination, Wood's light, a special device that use an ultraviolet light. Okay, use. تفضل. عاشت ايدك على هالسؤال. عادة skin biopsy, when you cannot reach to the provisional diagnosis or you have multiple differential diagnosis, cannot give this يعني انه تقول هذا disease، تبقى في شك. مثلا انت شفت فد skin ulcer وعندك شك هل هو هذا basal cell carcinoma مثلا أو squamous cell carcinoma. Is it basal or squamous cell carcinoma? You are in doubt. You can do that skin biopsy to confirm your diagnosis. And the biopsy, you can make incisional biopsy. Just take an incision, small part, and do the biopsy. And can be a diagnostic and therapeutic. We take all the lesion. Example, you have a nevus, and you want to confirm that this is an epidermal nevus, for example, as the benign. We take all the excisional biopsy. We make an excisional biopsy, excise the lesion, okay, and we send it for biopsy, for histopathological study, to confirm that the lesion. And at the same time, we have removed the lesion. We call excisional biopsy. Okay, so biopsy usually is the last step in diagnosis. The last step after we use special tests if we can, or you have Wood's lump examination, or do any other using any other equipment. The last thing we can do is a skin biopsy to confirm that diagnosis. واضح؟ الكترون مايكروسكوب هذا يعني احنا ما نسوي طبعا، ما موجود، not available عندنا، بس هو اكو شيء اسمه electron microscopy to study the cells، خصوصا باللس diseases or connective tissue diseases. We can do an electron microscopy. Patch test, we use it in allergical disorder. If we have example neurological disorders as in urticaria, urticaria, or we have dermatitis, contact dermatitis, and if it's allergic contact dermatitis, or it could type 1 hypersensitivity reaction or type 4 hypersensitivity reaction, we can do a patch test. We induce that allergic material to the skin and see see the reaction. Okay, we call it patch test. اكو two types، اكو open واكو closed، واكو different materials حسب البيشنت على شنو يعني ماده يتحسس من عندها. فتفيدنا بالدرماتيتس، الكونتاكت درماتيتس بالذات، كونتاكت درماتيتس. اوكي واضح للجميع. نرجع على الوودز لامب. الوودز لامب اللي هو a device, special device that give an ultraviolet light. okay, نوجهها على skin and see that there is changes in the color. عادة يصير هي process of absorption of the light and reflection of the light. absorption and reflection فتبين الديزيز اللي شنو يصير بها absorption، اللي يا cells تسوي absorption لللايت ويا cells يصير pass through pass through الultraviolet light فينطيني الconfiguration or changes بالليجن. مثلا example ميلازما، vitiligo راح تبين more تكون more obvious by using an a Woods light examination. Also it's يعني it's useful in infection, most commonly fungal infection. There is fluorescent light appear, pityriasis versicolor, yellow light appear. This is because of absorption and pass through the light, the ultraviolet light through the skin. Bacterial also color, bacteria as in Phrasma is most commonly colored by a specific color. It's coral red color, coral red. نشوفها بالإرثرازما. For example, are some changes in color seen in infection. قلنا pigmented disorder as melasma and vitiligo is useful to use a Woods lab examination. شوفني configuration وال depth of the lesion. As in melasma ممكن نشوف إذا كان superficial melasma or deep in the dermis, epidermal or dermal melasma. The porphyria also is useful. It's a red color. مثلا للgums إذا كان أكو deposition of porphyrin. Also drugs and chemicals, tumors, infestations, other use للWoods lamp examination can help. هذا الWoods lamp هذا اللي بالصورة ده تشوفون هو coral red seen in erythrasma. نسلط الضوء مال الWoods lamp على السكين. طبعا لازم dark room حتى نشوف الرفلكشن مال اللايت. dark skin dark room ونسوي نسلط الضوء على السكين الWoods lamp فيطلع لي ريفلكشن مال color لونه أحمر red تسمي coral red. هذا specific in erythrasma. آخر شيء وصلنا تقريبا هو السلايد روم. التست اللي نستخدمها أكو فشي نسميه KOH examination. KOH examination نستخدم مادة البوتاسيوم هيدروكسيد يفيدنا بالدايجنوزز مال السكين انفكشن سكين فانجل انفكشن مثل التينيا. نجيب سلايد glass slide we put a small piece of skin rubbing للسكين تسوي في scraping للscales و collect these scales or put it on the glass. We put drops of KOH examination and leave it to dry for 10 to 15 minutes and then examine it by using a microscope. We usually see hyphae and spores, useful in the diagnosis of any hyphae or spores like in tinea, candida, or other diseases, other fungal infection that contain hyphae and spores. We can see also pseudohyphae, pityriasis versicolor, also it's useful in diagnosis. And scabies, detection of scabies mites, cytology as Tanzac smear. These are useful diagnostic process used in side rooms. The diagnosis of herpes simplex virus, herpes zoster virus. And we have also patch test. هذه مجرد تعرفون الأسامي التست اللي ممكن نستخدمها to aid or to help us in the diagnosis process. الباتش تيست هو قلنا نستخدمها في allergic problems detecting allergic contact dermatitis. عادة نخلي material احنا نشك هذا الماتيريال سبب allergy للبيشنت نعرض ذاك الماتيريال على السكين و read the process if there is a reaction or there is no reaction, measuring these factors and see. عادة بتصير إذا أكو redness، إذا أكو papule formation، إذا أكو vesicle formation، كلها تنطينا grade أكثر. Other tests we can use also for detection of immediate type 1 hypersensitivity reaction is prick tests. We make prick in the skin with a special wood or material that contain that allergen. But usually we بنسوي البريك تكون superficial. we don't induce bleeding ضروري حتى يطلع لنا البريك مضبوط. either after 10 minutes تقريبا راح نشوف الرياكشن اللي راح يصير if there is any wheel formation. كل ما كان الويل أكبر كل ما كان هذا المادة مسببة allergy أكثر. كل ما كان small يعني إنه يكون الالرجيك process مالها mild. عادة البريك تيست تسوي detection لل immediate hypersensitivity reaction while the patch test delayed hypersensitivity reaction. Skin biopsy, as we said, we have either excisional biopsy or incisional biopsy. ونستخدم الاكزيشنال biopsy قلنا كتريتمنت also removal of the lesion with normal skin surrounding. ممكن ناخذ في حالة عندنا doubt that it is a malignant lesion. Punch biopsy, we take only a punch from the lesion. So a punch biopsy, special tool that we can make a punch just from a lesion. Take the lesion. It's a punch biopsy. Incisional biopsy, gonna make a small crescent incision and study it. Curettage, by using curettage, we take the lesion as seborrheic keratosis, molluscum. We can use the curettage. We have shave biopsy, make shaving by the blade, just to take the top, shave biopsy. When you have, for example, a nevus, an epidermal nevus, or a dermal nevus, you can just make a shave biopsy and remove. طبعا لا painful فاحنا ننطي local anesthesia ليدوكاين. ننطي ليدوكاين للبيشنت. اوكي عادة ننطي by local anesthesia by using lidocaine either incision or make according يعني ممكن نسوي nerve block إذا كان ليجن مثلا كبيرة مثلا، أو مثلا نسوي مثلا biopsy للنيل removal of nail avulsion نقدر نسوي nerve block ننطي lidocaine direct on the nerve or نسوي multiple incision يعني multiple punctures. ننطي local anesthesia in multiple areas around the lesion يصير local يعني local anesthesia. Okay. Other tests ممكن blood test help us in the diagnosis. إذا ممكن ناخذ other complete blood picture, hemoglobin, other problems يعني ممكن نحتاج other blood test, immunofluorescence testing, okay, ECR, urine test, other lesions, other يعني tests can help us. وهنا وانتهت محاضرتنا لليوم إن شاء الله تكونوا استفادتوا. الحكي هذا كله clinical. by clinical practice راح تشوفوه تطبقوه more easier than تشوفوه نظري. بس هو تاخذون فكرة عن الموضوع واضح للجميع. واضحة؟ أحد عنده سؤال أو استفسار؟ أحد عنده سؤال أو استفسار؟ ماكو أحد عنده سؤال؟ اللي